So again, thank you all for coming to this talk with us. Like I said earlier, Monica and I are really passionate about this project, and it's been a long time in the works, so we're happy to present it to you all today. So you can see that's our very long title right there, but essentially we wanted to go to Guatemala and talk to the people there, the population that we serve, and see what their perceptions are about osteopathic medicine. And then while we're doing that, we also wanted to see how OMM can help people with their pain, and that how relates to how satisfied they are with us being DOs with the medicine that we provide. So we already had a little introduction, but these are just some pictures we wanted to share of our travels to kind of, you guys can get a better picture of our personality. And there's my dog right there, Milo, that I love spending time with. And now Monica will take over.
Thank you, Grace. Okay, so my introduction getting to know me is a little bit long, so I do apologize. If you know anything about myself, is that I love doing anything that will raise my dad's blood pressure. So that's why in the first picture, cliff jumping. I love being outside, and I'm also from Toronto, Canada. So I really love this picture because it just reminds me of home. And I'm just very fortunate to have two really great, loving parents who always support me in everything and anything that I put my mind to. So I always appreciate that. And then my last one is a picture of us in Kansas City after the Chiefs won. And I like to think that I'm the Chiefs' little gem because every time I've gone, they've won, but that's obviously not true. But yeah, I'm just very happy to present today. So I'll have Grace hit the next button and we'll get started. Okay, so first I wanted to just introduce Guatemala. So Guatemala is a country in Central America who is kind of a little bit of small, but it's still a great country, and Grace had the opportunity to visit there. And Guatemala, 10% of its population live below the international poverty line, which is $2 a day. And, for us, that's like not even like a coffee sometimes. $2 a day for someone to live on is extremely, extremely low. And with that comes a lot of agricultural aspects to the labor that they do every day. So a lot of these families that are in Guatemala that live below the poverty line do a lot of work in agriculture. And if you know anything about agriculture, you know that you're standing outside in the heat. It's very taxing on the body because you put a lot of weight on your back, and overall it's just a very intensive job. And with that in mind, that creates a lot of musculoskeletal strain onto these patients and population. So that's why we were very interested to see how us as DOs can influence the Guatemala population to have a little bit of better understanding of what it is that we do. So now I'm going to talk a little bit about the relationship with Guatemala and KCU. So KCU has actually been going to Guatemala for the last 20 years. And these are some pictures from Grace's last trip in Guatemala. And I just think it's really cool that we have this relationship with the community, but it's very interesting. And we wanted to better understand what this community understands about osteopathic physicians. And if there is a gap that we can bridge there so that we can better utilize all of the things that we learn as osteopathic students to aid these populations. So that's why in the following slide, we're going to talk about, how does Guatemalan populations look at pain. So this is very common in non-Western medicine, that the very first thing that anyone does when something feels like they're hurting is they reach out to get the first pill that they know. And to us, it might be ibuprofen, but to a lot of people, they have no idea what they're reaching. They just know that if they take that pill, it reduces their pain. And, sometimes that can be very nerve-wracking because it's like, what are our patients taking, and like, how much are they taking? Because we know what effects that has, but a lot of populations don't. And that's where OMT is very helpful because, when you perform OMT, like there's not a lot of pain that you cause the patient. There's just, if any, side effect, soreness, which is something that goes away. So another thing that we want to talk about regarding ibuprofen and just in general medications that patients may take in these populations is a lot of the medications are controlled by private sectors. So if someone's living on $2 a day, their availability to get these medications is already reduced, because not only do they have to worry about these $2 a day lasting them to, feed their families and, ensure that they have a at least some sort of quality of life. When it comes to pain, a lot of the times it just gets ignored because they don't have the accessibility to, reduce that pain. But that just creates a vicious cycle, because if anyone gets sick, or if anyone gets hurt because of this musculoskeletal strain, they cannot earn those $2 a day. So that's why we thought it was very important that we started to get a better understanding of what these populations that we've been working for the last 20 years have when it comes to osteopathic manipulation therapies. So now Grace is going to talk more about our project.
Just to quickly add to what Monica was saying, I'll go back to the previous slide about the access to medication for these musculoskeletal pains that a lot of people in Guatemala have, especially low back pain. What I kind of witnessed when I was over there last month is that since they don't really have a good amount of access to get any sort of like ibuprofen or NSAIDs or anything that will help relieve their pain, a lot of these people just kind of suffer with their pain. I saw so many patients that would tell me, oh yeah, I've had back pain for years and I just kind of live with it and it bothers me, but I don't really know what to do. And when I would ask them if they've ever taken anything to help with their pain, they're like, nope, I don't take anything at all. So that kind of goes to show you that feel like as osteopathic physicians, any OMT that we can offer and we can teach them even how to do certain techniques, I think that would greatly benefit their pain that they deal with here. So more about our project. So our specific questions you can see right there. So it's kind of two-folded. So our first part, we wanted to see how OMM can really help low back pain in these populations, and if offering OMM and kind of going through that process as osteopathic physicians when we are treating people, if they are able to understand or know our osteopathic principles in our what we practice. So, and then we also wanted to see the perceptions that they have. So this is just kind of how we went about searching for everything. We used PubMed, and this is kind of some things that we were looking at. We want to look at low back pain, what specific OMM can be treated for low back pain, what is the healthcare like in Guatemala, what is the access that they have, is it hard for them to go see a doctor, what are the costs for it, and then like we were talking about that pharmaceutical inaccessibility. So for our methods, our inclusion criteria, we wanted to look at people that were 16 and over. They had to be able to answer the surveys, able to give consent. 16, you're considered a minor. So we wanted to also make sure that we had the parental consent, child's assent. And then we also wanted to know that if they had low back pain for more than 6 weeks. And that was, I'll talk about that a little bit later, but that was part of one of our surveys. And then the exclusion, anyone under the age of 16, if they have other MSK complaints or any other significant comorbidities. So after that, for people that had the low back pain, we would give them OMT that was specific to them. We didn't want to make everything super standardized. We wanted to be able to treat them effectively. So you can't give everyone the same type of treatment. It depends on what specifically they were complaining of and what you find. And then the outcomes, we were just going to see their overall satisfaction and then hand in the survey to see what they understood about osteopathic principles. So their study design is mostly just survey-based, and then again with that OMT treatment. And then I am fluent in Spanish, so I was going to be there if anyone needed help with reading the questions, answering them, and then explaining all of the OMT treatment as well. And all of the surveys were, of course, translated into Spanish. So these are some of our surveys. So OSTRI Low Back Pain Disability Questionnaire is the gold standard for assessing how severe a patient's low back pain is. And we kind of modified it. We added some questions about if they've had back pain for longer than 6 weeks, if they ever had any surgery, if they take any medications for their pain. And the questionnaire kind of goes through how intense the pain is, how it affects their daily life activities, like does it hurt to walk? Does it hurt to sit? Can you take care of yourself? What difficulties do you have? And then on the bottom right here, the score. So each kind of box has a rank or a number of 0 to 5. So 0 would be the first one, and then 1 would be the second one. So based on their scoring, you would assess their disability level for their low back pain. And then this is the VAS. This is just to see for them to point on a scale of 1 to 10, like how bad their pain is. And then this was our modified OsteoServe. The OsteoServe is a way for osteopathic physicians to assess how well patients are satisfied with their care. So we kind of took that and we modified it to make it a little bit more relevant to the Guatemalan population. So we have general questions on there about socio-demographic stuff, baseline for their health care, and then we kind of went into questions about their sort of satisfaction and about if they're familiar with the osteopathic tenets, if they've ever been seen by an osteopathic physician, and how satisfied they were with their OMT treatment, stuff like that. So that this was kind of like the big part of the research. So the way we would do it is we would screen patients based on if they had low back pain. So they would come to clinic, get seen. If they identified having low back pain for more than 6 weeks, we would give them that OSTRI low back pain questionnaire first, along with the VAS, to kind of see where they're at right now with their pain. Then a student or a doctor would perform OMM for their low back pain in whatever form that they needed for their relief. And then afterwards, they would do the VAS again, the little pain phase scale, to see how their pain is after receiving treatment. And then we would give them the OsteoServe after everything has been completed to see how satisfied they were with all of their care. And again, if someone needed it to be translated, I would be present. And I think I'll pass it over to Monica now.
Okay, so now we want to talk about some limitations in our project. So OMM OMM research can be a little bit complicated because the main thing being that the way that we do things in terms of pressure can differ from person to person. So it's very important that if you perform a technique and you're trying to see, did this technique work or was this technique helpful for that specific patient? Are we all using the same person and are we using the same amount of pressure each time that we perform the technique? So one of the things was that we would have liked to have some sort of like weight or something that would have, been able to calculate how much pressure the person was putting each time that they were doing their project. Another thing that we looked at as a limitation was just the lack of control group. Like we weren't sure if by having a control group, we would be able to further standardize our research. But again, it is a qualitative research, so then that could also be something that we consider doing in the future. And then another thing is we are going into a new culture. And even though Grace and I are Latinas, like we are not from Guatemala. So there's definitely a lot of different biases that we ourselves bring. And it was just very important that when we did this research, there was a good communication between the patients and the community health workers there, because at the end of the day, this research isn't necessarily just for us, it's mostly for the patients. It's for the patients to get some sort of osteopathic manipulation to help treat their pain. And hopefully in the future, that can translate into something else, which we'll talk on the next slide. And then the last thing was just time constraint. We had a very limited amount of days to do this in clinic. So that was one of the other things, and just trying to get everything, approved through the IRB and making sure that we had everything ready for Guatemala was a limitation that we had. But that's why I think it's an excellent project to be continued onto by the next group of global health students that do go to Guatemala. So on the next slide, we'll talk about future directions. So we definitely want to, like I said, continue this project into 2025, especially for the students that are going to Guatemala again next year. And I think the main goal we want to kind of get with this project is just to train community healthcare workers in myofascial release. Myofascial release is the very first thing that we ever learn as students. And it's, looking back, it's not as hard as I thought the first time I did it, because you just start to get better and better as time goes on and the more you practice it. So I definitely think that it would be amazing if we could train community health workers in myofascial release, because we're already talking about a community and that doesn't have access to medications as often as we do, that have socioeconomical constraints, and being able to provide and empower a group of people to perform something that would help with low back pain would be something that I don't even know if I could even describe it into words, because it would just be something that us as KCU could leave forward into those communities. And then another thing is we just want to continue projects like this, because it's very important that research has minorities included in research. As we know, there's not a lot of minorities that are included within research. A lot of it is just what's it called, like white like Caucasian populations. So it's very, very important, because our population no longer looks like that. Our population is very diverse. And if we continue to advocate and include research that includes different kinds of minorities, then we're actually creating a better representation of our current diverse population, which is the goal with research. So yeah, that was pretty much what we did. And there's a last slide, and it's just basically our references. We're happy to get any questions or any ideas that anyone feels like it would be very helpful for a project, because we definitely want to continue it. So anything is welcomed.